Okay, so we have to start from joint pain and we'll finish the family medicine. So the next topic is joint pain. What if a patient is presenting to us with joint pain? As usual, always start with history. Take a proper history, move on to the physical examination. Depending upon the history and physical examination, we are going to see if the patient needs any further investigations or no. So first, what are we going to ask in the history is the patient is presenting with a pain in the knee joint. So we're going to ask him whether it is one joint, more than one joint, same area joints, different joints. Then is it inflammatory or non-inflammatory? We have to first differentiate this. And how will we differentiate that? On the basis of history questions. So in the history, remember warm for inflammatory joints. What is the patient going to say? That the pain is worse with rest and better with activity. Worsening in the later half of the night. Redness around the joint. Morning stiffness more than 30 minutes. And then soft tissue swelling and erythema. So this is the differentiating point between inflammatory and non-inflammatory. So if he's giving us a history that, doctor, when I wake up in the morning, I have stiffness, it lasts for at least 30 minutes, then it slowly gets better. When I do some activity, it gets better. So it is most probably an inflammatory joint. Then, and what are the examples of inflammatory joints? Like rheumatoid arthritis, it is like inflammatory. So we just have to differentiate those. Then pattern of joints involved symmetrical versus asymmetrical, large versus small joint, axial skeleton. Onset, did it start all of a sudden or did it start slowly? Like he had some mild pain for the last 2-3 months, but now it is increasing and it is so chronic that he can't bear it anymore. Then about the past history, did he have any recent trauma, any infections? Sometimes some viral infections do lead to some inflammation of the joints. So we have to exclude all these things with a proper history. Okay, viral infection, maybe he had some STI recently. So for all of these things, we will take history, ask him whether he's diabetic, is he on any medications, like steroids are associated with osteoporosis, decreased muscle mass, decreased bone mass, leading to bone and joint pain. Any history of any rash, psoriatic arthritis. He might just come up to us and he says that I have a history of rash, I have this silvery scales on my body, and I'm getting treatment for them. But now for some time, I have pain in my joints also. So it can be psoriatic arthritis, any myeloma, then any osteoporosis, any osteoarthritis. So we have to take a proper history. Then what will we do after the history? We will move on to the physical examination. In physical examination, for different scenarios, because joint pain is not just limited to one thing, right? So for every different underlying cause, there are some specific tests which we have to do. So those tests, when we're going to study in rheumatology and ortho, then I'm going to tell you. But still, you should know that if there is some specific physical examination for a condition, we have to do that. We have to write that. Then in the psoriatic arthritis, they may present with some changes in the nail. So we have to check them. And remember, these pictures are also important. So they might give you the X-ray of some joint and asking you, what is this? So do look into the joints. I will conduct in the end one session for the X-rays and different pictures also. Okay, then for the investigations. What are the investigations? Journal investigations are CBC, differentials, electrolytes, creatinine. ESR, CRP. Maybe he had some recent viral infection, inflammatory infection. So that we will do ESR and CRP. Complements, C3, C4. What do we do that for? SLE, any autoimmune disease. He might have some underlying autoimmune disease in which they might be decreased. Then we have to do urine analysis to detect any proteinuria, active sediments. These are all autoimmune diseases. And depending on the presentation, like if the patient is presenting with some fever, with some rash, with some proteinuria or hematuria or urinary symptoms, then he might be having SLE. So we will, according to the history, if they are giving us the history of SLE and specific butterfly rash, and along with that joint pains, so we can think of SLE, and we have to do then okay, ANA is just, it is not a diagnostic test for SLE. Remember, if they're asking for the diagnostic test, what is the diagnostic test for SLE? It is double-stranded DNA, anti-double-stranded DNA or anti-Smith antibodies. These two are the diagnostic tests for SLE. Similarly, for if they have any history of any rash, same SLE, any psoriasis, so we will check accordingly. Any nail abnormalities are present in what? Reactive arthritis, psoriasis, uveitis is associated with psoriatic arthritis, reactive arthritis, ankylosing spondylitis. Myalgias, fibromyalgia, myopathy. Fibromyalgia is a clinical diagnosis. No tests are done for it. Then any weakness, he might have any neuropathy, polymyositis, any gastrointestinal symptoms. For scleroderma, the patient might present with symptoms of GERD, regurgitation, tightening of the skin, Raynaud's phenomena, and now he has these symptoms, and now they also have what? Joint pain. So we will do the specific test for that. IBD, inflammatory bowel disease, Crohn's disease is associated with ankylosing spondylitis, other joint pains. Then genitourinary may have some gonococcemia, recent history of any STI. He might have reactive arthritis, any gonococcal arthritis. Gonococcal arthritis is migratory arthritis. He will come to you, the patient, he or she, and she will give you a history of STI, but she will say that now I don't have any urethral discharge, don't have any symptoms of STI, but now what do I have? I have pain in the joint. And he will say that one day the pain is in my knee, now the other day it is in my elbow. So he will say that the pain keeps on changing. So that is also one of the diagnostic for this gonococcal arthritis. After the specific investigations, we have to do the treatment according to the presentation of the patient. If it's just simple osteoarthritis, nothing else, we will educate the patient. We will do lifestyle modification. Old age patient coming to you above 70, 80 years, and he is asking you that, okay, I do some physiotherapy, I do take my acetaminophen or my NSAIDs, but still I have pain. So what is the next step we are going to do? We are going to provide them with some orthotics, some canes, some assistive devices. Then nothing else can be done. So if they are asking, they have given you in the scenario that, okay, the patient has been on physiotherapy, has been on NSAIDs, and still his condition, he's not having like any improvement, and he's here for the next step. So what will we do? We will give him some canes and assistive devices, walkers. Then always remember, if the patient is coming to us with a joint pain, we will start with acetaminophen. Okay, for simple joint pain like osteoarthritis, we always start, first line is acetaminophen. If the patient comes back, they say that, okay, I have been using acetaminophen, but my symptoms are not resolving, it is not helping me. Then what do we? The second is NSAIDs. And all of these pharmacotherapy, they go along with physiotherapy. Okay, along with some lifestyle modification, we'll tell them some weight-bearing exercises, the swimming, regular exercise, eat a healthy diet. If they're a smoker, quit smoking. If the patient comes and he has even used NSAIDs and still the symptoms are not resolving, so after that, what is it? We can add NSAID plus codeine, the third line. Okay, so acetaminophen, NSAIDs, and then codeine. Don't choose, like if a patient is coming and he's saying, I have NSAIDs and I have a very severe pain, he cannot bear it, he's old age, this and that. No matter how severe it is, never use opioids or morphine as your option. It is going to be the very, very last resort. And for joint pains, we don't even give that to the patient. Okay, so we start just with acetaminophen. And if he's coming for the first time, no matter how worse the pain is, start with acetaminophen. If he has some other like anti-inflammatory disease like rheumatoid arthritis, then of course we have to start him immediately on DMARDs. Okay, that depends upon the condition. If he has some SLE, we will start the patient on steroids. If he has some STI, some other infection, then we start on antibiotic. Okay. Then we have low back pain. So in low back pain, we will first, I'll just go through this red flags and then we'll go to the table at the end. What are the red flags? You should know these red flags on your fingertips. Very important. Bowel and bladder dysfunction, saddle anesthesia, constitutional symptoms or malignancy, chronic disease, paresthesia, age above 50 and mild trauma, IV drug user, and neuromotor deficits. So these are the red flags. If the patient is presenting with back pain and has any of these red flags, we have to urgently refer. Now, it depends. We have to, suppose if the patient is coming to you and he has saddle anesthesia or some neurological features, paresthesias, we will urgently refer to the ED. Okay. But if the patient is coming to us with back pain and has some constitutional symptoms or has a history of malignancy, like any lung cancer, any prostate or breast cancer, and now he has back pain also. So then we can, within a week or 2, we can refer the patient to the specialist. Okay. So depending upon the scenario and the conditions, we will refer the patient. Then if it is less than 6 weeks, it is acute. 6 to 12 weeks, subacute, and more than 12 weeks is chronic back pain. And in back pain, if a patient is presenting, we do not do X-ray. Okay, it's a clinically we treat it, we diagnose it clinically. Only X-ray is done in these conditions. Okay, lumbar spine X-ray is indicated if after 6 weeks there is no improvement, fever is more than 38, unexplained weight loss, he has some constitutional symptoms, so it might be referring towards some malignancy. He's using corticosteroids for the long time. The patient had any significant trauma, progressive neurological deficits, suspicion of ankylosing spondylitis. In ankylosing spondylitis, what would we see on X-ray? It would be bamboo spine, fusing of the spine together. Then history of cancer, alcohol or drug use, increased risk of osteomyelitis, trauma and fracture. So if any of these things is present, we will do lumbar spine X-ray. Otherwise, no X-ray. He's coming to you for the first time. He's fine. He's just saying that I have back pain. Then no X-ray. Okay. It's mostly 98% of the times it is mechanical and it gets resolved on its own. Then this is quadra ecuna. What is quadra ecuna? It is a surgical emergency, and in quadra ecuna, he will present with saddle anesthesia, fecal incontinence, urinary retention, areflexia, lower extremity weakness. So if the patient is presenting with any of these symptoms, it is an emergency. We have to immediately refer him to the emergency, and in the emergency, decompression has to be done. Okay. So if any of this, always remember what quadra ecuna is and what are the signs of quadra ecuna. It is very, very important. Just know the signs and the treatment of it, that immediate, urgent, we have to decompress it. Then abdominal aortic aneurysm may have a pulsatile mass in the abdomen, and patient might have a rupture of the aneurysm and he's presenting with back pain. Okay, then this is the chart that is important. So if the patient is presenting to us, first of all, with back pain, he comes to us and he says that, doctor, I have back pain. What will we do first? We will look for any red flags. If the patient has red flags, we have to, within hours, emergency referral. Okay, so any signs of quadra ecuna, emergency referral to the ED. If he has any other pain, like constitutional symptoms, any use of steroids, IV drug user, then on urgent basis, within 24 to 48 hours, we can refer the patient. And soon means within weeks. So if it's 50 years, more than 65, first time he's presenting with the pain, or he has widespread neurological symptoms, then we can also refer within weeks. But if quadra ecuna is there, emergency. And then what if the patient has red flag? Refer to the emergency or the rheumatologist. If there are no red flags, he is fine. He says that, okay, I don't have any red flags. It's just mild pain that started. So we have to ask him whether the pain started like before 12 weeks or it has been less than 12 weeks. And so in acute or subacute, mostly the treatment for both is same. So what we are going to do, first we're going to educate the patient, then prescribe him self-care strategies like heat and cold massage, padding, he can use that. Then encourage a return to work. Sometimes what do people say, do that they have a back pain and they take absent from work, that we cannot work. So we have to encourage him and tell him that he has to return to work early. The early he returns to work, the more earlier he'll get better. Recommend physical activity and exercise. Similarly, consider the analgesics, acetaminophen, NSAIDs, then short course muscle relaxant, and opioids rarely used. That is for severe pain. So along with that, the spinal traction is not recommended. After we do all this, we follow up the patient in 1 to 6 weeks. Again, the patient is coming on follow-up. We are taking a proper history, monitoring him and reassessing him. Are the symptoms getting better or worse? If the symptoms are getting better, fine, good. If the symptoms are not resolving, still he says that, doctor, no, my symptoms are not resolving. If we start in him acetaminophen, we can switch him to NSAIDs. Okay, consider PPIs, that if he's taking PPIs, he has any ulcer, then we won't give NSAIDs. Okay, so now what will we do? We will refer him to some physiotherapist, some chiropractor, physical exercises, social workers, multidisciplinary programs, because there's no underlying serious cause. So we have to then manage him according to this. We won't just refer him or do some imaging or some high advanced CT scans, no. Then depending upon that, if the patient is coming after, after 6 weeks, the pain is very severe and we see that still, okay, he might need an X-ray, then we can offer a lumbar spine X-ray. Otherwise, no. Then if the patient is coming to us and it's been more than 12 weeks, nothing serious is there, no red flags are there. Similarly, acetaminophen, NSAIDs, low-dose TCAs, and short-term cyclobenzaprine. Then refer for the community services, rehabilitation programs, behavior therapies. We can add some acupuncture, massage therapies, all of this. And in a moderate to severe pain, then we can give opioids. Okay, and that also for opioids, there's a proper assessment we have to do. And then we can't just start patient on opioid, because with opioids, the risk of opioid abuse is very high. So whenever the opioids are prescribed to a patient, they are monitored and they are given in a limited dose. And if the patient is coming back to you before the dose has ended, it means that maybe he's misusing the opioids. Okay, so we can't just, if the patient is coming to us and we gave him opioids for 2 weeks and he's coming back after 1 week and he says, I want my medications, and they finished. So we have to inquire properly what happened to the opioids. You still have 1 more week left, because then the doctors can't refer them without proper monitoring. There's a proper department that monitors and controls the release of opioid, even to the doctor. So doctor has to tell the patient that, I'm sorry, but I cannot prescribe you medication. And what happened? You took extra dose. Where did the opioids go? And it means that you are misusing them. So what will we do? We will then switch them to another medication. Okay. Then similarly, refer them for physiotherapy, other multidisciplinary chronic pain programs. Now, if the patient has non-traumatic, no trauma, simple back pain, then we have to check whether the pain is back dominant or leg dominant. Okay, so in back dominant, we have 2 types, pattern 1 and pattern 2. In pattern 1, most probably disc pain. And what is the disc pain? It will be worse with flexion and better with extension. Only patient will say that the pain is more in my back area above the gluteal fold and It is worse when I flex, when I bend forward, and it gets better when I extend. So that is most probably disc pain. Then if the pain is worse with extension and better with flexion, what is it? Is it facet joint pain? Okay. Similarly, if the patient is coming and he's saying that the pain is more leg dominant, what does it mean? That the pain is more below the gluteal fold. So there can be two causes, either sciatica or neurogenic claudication, that is spinal stenosis. So in sciatica, the patient will say that the pain changes with back movement or position. When I change the position, the pain also changes. And there are two tests for sciatica. We do the straight leg raise test and cross straight leg raise test. So if they are positive, it means that patient has sciatica. And for spinal stenosis, the pain is worse with activity, improves with rest and change in posture. Okay. So when spinal stenosis, we can ask the patient, is if the pain is worse with going up the stairs, down the stairs, like that. So treatment for all four of them is the same. What is the treatment? Lumbar roll, lumbar roll, lumbar roll, lumbar roll. Okay. Exercises and lumbar roll. So just remember, if the treatment they ask for medications, acetaminophen, NSAIDs, lumbar roll, acetaminophen, NSAIDs. So this is the treat for all four of them. Presentation can be different, but the treatment is same. Okay. Then we have menopause. Menopause is very important. And along with this, the hormone replacement therapy is also very important. And I will cover this in gynae because we have a proper chart and table over this. I want to cover it over there. So we will do it over there. We should know that, okay, a patient is coming with menopause, when we are prescribing the patient hormone replacement therapy and when we are not. Okay, what are the indications? What are the contraindications? If we are not giving the patient hormone replacement therapy, then what is the thing that, what medication we have to prescribe them according to the risk factor, according to the presentation, the treatment also changes. Okay, it's not that the patient has menopause, simply prescribe hormone replacement therapy. No. So according to the symptoms, the treatment will also change. So we'll discuss this in detail in gynae. Then we have osteoarthritis. What is osteoarthritis? It is progressive deterioration of the articular cartilage and surrounding joint structures caused by genetic, metabolic, biochemical, and biomechanical factors with secondary components of inflammation. Okay, and you should know that in osteoarthritis, what are the joints involved? Okay, in the hand, the distal interphalangeal, proximal interphalangeal, and first carpometacarpal. Then hip joint is involved, knees joint, first metatarsalophalangeal, spine, which one is involved, lumbar spine, which joints are involved. So you should know, because on the basis of these, especially the joints in the hands, on the basis of this, we can differentiate osteoarthritis from rheumatoid arthritis. In osteoarthritis, distal interphalangeal joints are involved, and in rheumatoid, these ones are involved. The proximal one are more involved. Okay. Similarly, when the cervical is involved, atlantoaxial joint is more involved in rheumatoid arthritis and can be a complication of that. Okay, so what will the patient present with? Mostly it is in old age, above 65 years old, 60 years above, old age patient, they will present with osteoarthritis. And what will they have? Pain with activity, improved with rest, morning stiffness or gelling, less than 30 minutes. So they may come and they say that I have morning stiffness, which lasts less than 30 minutes. And sometimes they do say that in the books, you might find that for rheumatoid arthritis, they have written that the morning stiffness is more than 30 minutes. And for osteoarthritis, it is less than 30 minutes. But that is not the main differentiating or the diagnostic point. Okay, that is just for the books. Then deformity, bony enlargement, crepitus, limitation of movements, periarticular muscular atrophy usually affects distal joints of the hand, spine, hip, and knees. Then these are the bony enlargement. The crepitations will be present on the examination. And then limitation of movement also on the examination. Then if we do the X-ray, what will we find? We will find joint space narrowing, subchondral sclerosis, subchondral cyst, and osteophytes. There may be some other physical examination findings like Herbert nodes, Bouchard nodes, squaring of the thumb, but they do occur in very late osteoarthritis, not in the initial stages. Then what is the management? Same, pain management. Physical exercises, conservative in osteoarthritis, patient education, weight loss, low impact exercises, assistive devices like canes and orthotics. And in the pharmacological, start with acetaminophen, move to NSAIDs, and then combination acetaminophen plus codeine. So this is first line, second line, third line. This is how we have to remember. They can give you a scenario and they can say that a person 50 years old and he has been, he was using acetaminophen for his osteoarthritis, but now his symptoms are getting worse and he also has some ulcer. He is a patient of peptic ulcer disease or is on long-term PPIs. So what? We cannot give him no NSAIDs, right? So what will we do? We will skip NSAIDs and we will move to acetaminophen plus codeine. Okay, it is also known as tramadol or whatever the option is. If they have given it in the MCQs, and either duloxetine or this is present, we can choose any one of this. Or if it's a CDM question, then you can write anyone. Okay. Then we have, and remember this intra-articular steroids or hyaluronic acid injections, these are not done like very frequently, okay? What they want us to know are the initial treatments, acetaminophen, NSAIDs, Dulox, like initial steps, patient is presenting, we are educating how we are educating the patient, how we are dealing with him. And then still if they're giving us these intra-articular injections and stuff, we are not even doing it. We have to refer because it means not, it is beyond our hands. So we have to refer them to the ortho people. They will see what they have to do next. Over here, back home in Asian countries, what happened? The one doctor, he is dealing with everything, right? But here, every specialty knows his job and we cannot take his job. Whatever his job is, he has to do it. So where our jobs finish, we refer to the specialty and then they take over. It's their job to do that. And they are testing you for the family physician. What are you going to do in your office? Either you're treating them properly or you're referring every patient to the specialty, or what is your approach? Then we have osteoporosis. In osteoporosis, we have this chart. Let me just check, yes. And we'll do this. Okay. So osteoporosis, they can be very like different causes of it. We have to see according to the patient age and presentation, we have to check. Normal age, like a normal person above 65 years of age, men or women, they are presenting to us, even if they don't have any symptoms. We have to do their bone mineral density test. Okay, above 65 years, it is recommended one time we do it. But if the patient is less than 50 or 50 to 64 years old, then there are special circumstances in which we have to do this BMD. In less than 50 years, if they have any fragility fractures, use of high-risk medications like steroids they have been using for a long time, then hypogonadism, malabsorption syndromes like IBD, they have long-term ulcerative colitis, celiac disease, chronic inflammatory conditions, primary hyperparathyroidism, other disorders strongly associated with rapid bone loss. So if they have any history of these diseases, then less than 50 years, we will do BMD. Similarly, between 50 to 64, if they have any history of fragility fractures after age 40, prolonged use of glucocorticoids or high-risk medication, any parental hip fracture. So they might come to you and they say that, yes, we are fine, but my mother has a history of hip fracture. So then we also have to assess them. Then vertebral fractures or osteopenia. identified on radiography. High alcohol intake or current smoking. They are smokers for a long time, or they are alcoholics. Low body weight, less than 60 kg, or major weight loss, more than 10% of body weight at age 25. Other disorders strongly associated with osteoporosis. Only in these conditions we will do, less than age 65, we will do BMD. Otherwise, we will not do bone mineral density testing in anyone. Normally, it is recommended one time after 65 years old. Normal men and women, we will do it. Then we will assess the patient for any risk factors. How will we assess that? Now, low risk, moderate risk, and severe risk. If 10-year fracture risk less than 10%, on BMD, we will know this. If the risk fracture is low, less than 10%, then we do not have to do anything. Okay, and we will reassess the patient in 5 years. Then if the 10-year fracture risk is 10 to 20%, we move on to the X-ray. That is lateral thoracolumbar radiography, T4 to T3 to T4 to L4, or vertebral fracture assessment. And that will further tell us that what we have to do. We will start them on the pharmacotherapy or not. Assessing on that, we will check the T-score. If the T-score is less than or equal to minus 2.5, patient is more than 65 years, has additional vertebral fractures on the lumbar radiography, has rapid bone loss, has been using men, maybe for prostate cancer, they have on androgen deprivation therapy. They have a history of cancer and are androgen deprivation therapy. Women have breast cancer and are undergoing aromatase inhibitor therapy. So all of these conditions, any one of them, they have long-term use of steroid. Look, steroids are very important. Then after that, if recurrent falls, more than 2 falls in the past 12 months. Similarly, disorders strongly associated with osteoporosis, rapid bone loss, or fractures. What will we do? We will repeat the scan after 1 to 3 years, and then we will also start the patient on pharmacotherapy. If they are high risk, more than 20% of prior fragility fracture of the hip or spine, then we will always start them on the pharmacotherapy and we will reassess them regularly. So basically for both of them, above 10%, just and do the X-ray, and then based on the X-ray and these findings, reassess the patient 1 to 3 years and start on pharmacotherapy. If high risk, more than 20%, immediately start on pharmacotherapy. What we just discussed it. Yes. And what are the physical examination findings we will check? For osteoporosis, what are the exams? There are 2 exams, these 2. Okay. So what rib to pelvis distance less than or equal to 2 finger breadth, and occiput to wall distance more than 5 centimeters. So it is measured on physical examination. They make the patient stand with the wall, and then they measure the distance between the wall and the occiput of the patient. If it is more than 5 centimeters, it is osteoporosis. Similarly, they measure the rib to pelvis distance. How much is it? They make the marking, then ask the patient to bend forward. It increases, decreases. So it depends. It's a physical examination. But you should know the name of the examination. They will not ask you how to perform them, but they will. They do want you to know the names. And then we will treat the patient accordingly. Mostly, what do we give these patients for? We start them on bisphosphonates, alendronate, vitamin D, calcium. Okay. Rash will do an enderma. Then we have STIs. Okay, for STI, we have this table. Yes, we'll do this table over here. And we will also cover it in gynae. It is on the side. Okay. When an STI is detected in a child, if a child is, mother is bringing her in her, even if it is a boy or a girl, and they are bringing them in, okay, and you suspect STI, it is sexual abuse. So we have to evaluate for sexual abuse always, because in children, they cannot get STI like that. So something is fishy and we have to further investigate it. Similarly, STI risk factors, what are those? Sexually active male and female, less than 25 years old, unprotected sex, sexual contact with a known case of STI, previous STI, new sexual partner, or more than 2 sexual partners in the past 12 months. Street involved, homeless, substance use, IV drug users, all of these are high risk factors. And when they are coming in, we do screen them for STIs. What is the history we're going to take in sexual history? Number of partners, then is it male or female? Practices, what type of sex do they practice? Then what do they use any protection or no? Then family history of STIs, and we have to counsel then on pregnancy prevention. If a sex worker is coming to you and she has STI, so we will counsel her on protection, we will counsel her on pregnancy prevention. So all these things have to be addressed. The most common STI in Canada is chlamydia, and one of their favorite also. Okay, exam point of view, chlamydia, gonorrhea, very important. The patient will present maybe a homeless patient having urethral discharge, nothing else, and she's here or he's here for the medication, or what is the next step? So the investigation is NAT, and what is the treatment? Ceftriaxone and zithromycin. Okay. And if it's a homeless patient, so in them, what are we doing? We are not sure whether they are going to be compliant with their follow-up. So in those patients, if it's a homeless or sex worker, like these people, what we will do in our office setting, we will not wait for the test results. What we will do, we will just immediately in the office, we will give them ceftriaxone, azithromycin, because it's just a single dose. So we'll give it to them over there. If they come for the follow-up, well and good. Even if they don't come, they have a high risky behavior, they are not coming back, not following us, the treatment has been given to them. Okay, if we are suspecting it. So let's do this. Okay, so gonococcal urethritis or cervicitis, most common causes, and gonorrhea. In males and females, same. It will be like urethral discharge, any pyuria, dysuria, irritation, testicular swelling, female mucopurulent discharge, same dysuria, pain. Then the diagnostic test is NAT, nucleic acid amplification test. For both of them, male or female, we are doing NAT. Even for gonorrhea, chlamydia. Chlamydia also has the same presentation, and the test is the same. For chlamydia, gonorrhea, it is NAT. And whenever we are treating gonorrhea, what do we give? Ceftriaxone 250 mg IM, single dose. Okay, and for this chlamydia, we are giving azithromycin. Okay, orally, single dose. And if we are suspecting chlamydia, we will always treat for gonorrhea with it. Okay, so both of the treatment is together. If they're asking you about chlamydia, and write two pharmacological treatments we're going to give. So we're going to give azithromycin, single dose, and ceftriaxone IM, single dose. They're not asking you the doses. So just know the name and the route. So next, what is it? The complications are the same. And after we are giving the patient the treatment, we have to do the test of cure after 7 to 10 days, 3 to 7 days. And remember, test of cure is what? It is we repeat the test again to check whether the patient is now fine or no. Is the test negative or not? And it is not done in everyone. It is done in patient with high sexual behaviors, in pregnancy. If they come back and they say the symptoms are still there, then we do that. And we repeat the screening in all patients 6 months. After 6 months, we repeat the screening in all patients, but test of cure is only done in some specific population. And what are the complications? Complications are urethral strictures, epididymitis, infertility in male, and in female, it is PID, infertility, ectopic pregnancy, perinatal infection, chronic pelvic pain. So if a patient, a female is coming to you, she had like gonococcal or chlamydia, STI, any STIs, and now she is coming to you with lower pelvic pain, with fever. So it is most probably it is PID. The infection has spread. The virus, now it has now moved up to the upper part of the body. So it is most probably PID, pelvic inflammatory disease. Similarly, for HPV, we give vaccination, but if the patient, and in females, what do? We do the screening, cervical screening with pap smear every 3 years. But in male, we don't do any screening. If they just present with some presentation, ulcers, condyloma, then we treat accordingly. But if there's some abnormality in the pap smear, then we have to do colposcopy. Then the next step is colposcopy. And colposcopy, we won't do them. We will refer them to the gynecologist for colposcopy. Okay. So they might be asymptomatic, or they might just present with condylomata acuminata, or it might just be an accidental finding on the pap smear in females, something abnormal in the pap smear. So we will move on to the next step. And what is the treatment for condylomata? It is cryotherapy, electrocautery, laser excision. We have to remove it. Complications for male and female, it is anal cancer, MSM, and what is MSF? Men having sex with men, and female who have receptive anal sex, rectal cancer. So these are the complications, high risk patients who can have this. So we always have to screen them. And in female, cervical, vaginal, and vulvar cancer. Okay. Then for herpes simplex, type 1 and 2, in herpes simplex, the patient will present with some vesiculo-ulcerative, they will be very painful. Okay, remember, it is very herpes, they will have lesions on the genital area, some ulcers, which are going to be very, very painful. And the patient may or may not give you a history, but mostly they do have fever along with it. And lymphadenopathy would be, lymph nodes will be tender, enlarged and tender. And maybe some, it might be the herpes simplex virus is present in them. They never had the symptoms, but they may have some trigger factors, like the patient recently got some infection, some fever, anything which have decreased the immunity of the patient, and now the symptoms are there. So for this, what do we do? Swab for vesicular content for culture, that is the Zank smear we do, and we will see multinucleated joint cells in this or not. We are giving the patient acyclovir. If it is recurrent, again, for recurrent also, we are giving the acyclovir antiviral, but just the duration will change. Or we can give them prophylactically also. Complications are genital pain, urethritis, cervicitis, aseptic meningitis, increased risk of acquiring and transmitting HIV. Then for syphilis, we have primary, secondary, and tertiary. In primary, syphilis is painless. They might just come up to us, and in the genital area, on examination, there might be some painless ulcers present, known as chancre. Okay, so, and on a further examination, there will be lymphadenopathy. The patient might have some ulcers and he didn't even notice, or didn't bother to seek further medical treatment because they were painless. So on examination, they might be present. Or the patient may present with flu or rash-like symptoms, then meningitis, headache, uveitis, retinitis, condyloma elata, mucous lesions, alopecia. It can be in the body, it can be asymptomatic in the latent phase. Or neurologic symptoms, that is like tapes dorsalis, gait problems, cannot walk, has some paresthesias, some cardiovascular problems. So this is all in the tertiary syphilis. What will we do? The screening test for syphilis is VDRL. Okay, so we screen all the pregnant women, universal screening. If a pregnant lady is coming to you for the first time, we have to do the VDRL to screen her for syphilis. Otherwise, we are doing this VDRL in high-risk patients, okay, who are at high risk of syphilis. On the office visit, we have to, on periodic visits, we have to do VDRL in them. What is the treatment? Benzathine penicillin G, single dose. IM, single dose. Okay, one time just give it and that's it. Then we have notified the partners. Okay, for all of these, remember, these are notifiable diseases. We will report the public health and we will treat. STIs are reportable to the public health, and STI, we are not just treating the patient, we are treating the partner also. And first, we will tell the patient to take your partner into confidence and tell the partner and bring them along. If the patient refuses that, no, I don't want to tell the partner, what we have to do, then we have to inform the public health, and the public health will itself inform the partner, because both of them have to be treated in all these conditions. Then continuous follow-up and testing until patient are seronegative. And in tertiary syphilis, patient has neurologic symptoms. What are we, how are we treating the patient? With aqueous benzathine penicillin G. Okay, there we are giving, in neurological features, we are giving aqueous benzathine penicillin. Okay. Then what do we have next is sinusitis. In sinusitis, red flags, very important. What are the red flags? For urgent referral. Patient is presenting with any of these red flags, urgently refer the patient. Altered mental status, headache, systemic toxicity, swelling of the orbit or change in the visual acuity or extraocular muscles. Then hard neurological findings, signs of meningeal irritation, suspected intracranial complications, for example, meningitis, intracranial abscess, cavernous sinus thrombosis, involvement of associated structures, for example, periorbital cellulitis, pot coffee tumor. So what can this sinusitis do? It can, from the nasal cavities, it can migrate to other parts, our brain, our ear, and what can it, our eye, and then it can cause red flags or emergency symptoms over there. So we have to treat them emergently. How will we do? Mostly it is viral. Remember, sinusitis is mostly viral. If the patient is presenting with symptoms of sinusitis, any facial pain or runny nose, and it is just less than 7 days, we will treat symptomatically. Same saline rinses and increase water intake. For pain, we can give him some NSAIDs, acetaminophen. But if the symptoms are not resolving for more than 7 days, or the patient was presenting, and what happened after 3 to 4 days, the symptoms got better, but now he's saying that again, after getting better, my symptoms are getting worse. After 2 to 3 days, the symptoms were better, but now again, after 6 days, 7 days, my symptoms are getting worse. So most likely it is bacterial. So we have to treat it. After 7 days, more than 7 days, highly it is bacterial infection and requires 2 major symptoms. That is nasal obstruction or nasal prurulence or discolored postnasal discharge. And just remember this PODS one. Okay. If the patient has any of these POD symptoms, then it is acute bacterial rhinosinusitis, or if the symptoms are for more than 7 days, or if the symptoms were getting better and now again worse. So what is in PODS? Facial pain or pressure or fullness, nasal obstruction, nasal prurulence or discolored postnasal discharge, hyposmia, anosmia. He cannot smell anymore, or the change is, the smell has changed. So altered smell, all of these are the warning signs. It means that now it is a bacterial infection and we have to do something for it. Also consider what? Worsening after 5 to 7 days, biphasic illness. Getting fine, but now again worsening. Symptoms persist for more than 7 days without improvement, and presence of purulence for 3 to 5 days with high-grade fever. Any of this is present, it means it's bacterial, and we have to start the patient on antibiotics. But if less than 7 days, simple symptoms, treat it as viral, okay? And for viral, we just have symptomatic treatment. Then if it is mild to moderate, not very severe, we will start with inhaled intranasal corticosteroids. We will follow up the patient for 72 hours. If the symptoms are getting better, continue the treatment. If not, then we will consider antibiotics. Okay. What are the antibiotics we are given? Amoxicillin. If the patient has very severe of these symptoms, immediately start on intranasal corticosteroids plus antibiotics. Then clinical response in 72 hours. Yes, continue the treatment if he is not getting better with first line antibiotics. Then we move on to second line antibiotics. And what are second line antibiotics? Amoxicillin, clavulanic acid. Okay, intranasal corticosteroids plus amoxicillin. Not getting better, intranasal corticosteroid plus amoxicillin, clavulanic acid. Then again reassess in 72 hours. Getting better, continue the regime. Not getting better, consider chronic rhinosinusitis and urgent referral. So this is it. If the patient has recurrent, then what do we have to do? We have to refer or do the CT scan. And what is recurrent? With multiple recurrent episodes, consider radiology, that is X-ray of the or CT scan to confirm ABRS during episodes or to eliminate other cause. So if they're giving us a scenario and they're saying the patient is coming to us with recurrent acute bacterial rhinosinusitis, he had more than 4 episodes in the last year, or he had 5 episodes in the last year, and now he's again with another episode. So what do we have to do now? What is your next step in management? So next step would be refer and for X-ray. Okay. Did I miss anything? No, that's it. This is what they have. Yeah. So antibiotics, first line is amoxicillin, second line amoxicillin, clavulanic acid, or we can also give fluoroquinolone. Then ENT referral if any anatomic defect, for example, deviated septum, polyp, adenoid hypertrophy, failure of second line therapy, more than 4 episodes in the year, refer urgently for red flags. Then we have sleep disorders. In sleep disorders, we have, there are different types of sleep disorders. It can be insomnia. What is insomnia? The patient is not able to sleep. They go to bed, but they're not able to sleep. Just they have like less than 8 hours of sleep. They struggle, but they're not able. Then parasomnias. What are parasomnias? Abnormal behaviors during sleep. Like he may be giving a history of some night terrors, some sleepwalking, yes, night terrors, nightmares, restless leg syndrome, any cataplexy, narcolepsy. So these are all the parasomnias, abnormal behavior during the sleep. And then excessive daytime sleepiness, hypersomnia, that they sleep properly during the night, but still they are tired and they are fatigued and they need more sleep during the daytime also. So these are the 3 presentations, any 3 of them they can present with. Then according to the presentation, same, the etiology are, it's going to change. It can be maybe some lifestyle factors might be there. Maybe patient is working a double shift. He has night shifts and on the weekends, he doesn't have any shift. That's why he's not able to sleep. Maybe they traveled recently, long travel, jet lags. Maybe they have some depression, because in depression also they present with insomnia. What if the patient is taking coffee, caffeine, or smoking, or taking alcohol before bed? First of all, in the treatment, what will we do? We will tell them about the sleep hygiene. The patient is coming, telling us their symptoms. We're taking a proper history, asking them about all these things. For investigations, we will give them a diary. And we will tell them that every morning you have to write your routine in it. Like you in the sleep diary, what you have to do, you have to write every day that how much you slept, for how many hours, at what time. They will keep a proper record of it for 1 to 2 weeks. And then we will call them back and we will check them after 2 weeks that what does the diary say, reassess them. If we are suspecting any other underlying organic medical cause, like then we have to perform some investigations like CBC differential. They might be presenting with some symptoms of thyroid, so we have to do TSH. Refer to sleep studies, nocturnal polysomnograph. These come in sleep studies. When do we do? And this in obstructive sleep apnea. Okay. So according to the presentation, this is going to stop. Maybe the patient is coming with restless leg syndrome. He says that I can't keep my leg Like it's just all the time moving, and while I'm sleeping, I can't just keep it still. It's always, I feel that it's restless. So in that, iron deficiency anemia is a very common cause. So we won't just immediately jump onto investigations or some sleep studies or some. First, we have to do the basic test will be iron studies to rule out maybe it is the underlying cause is iron deficiency anemia. So for primary insomnia, what is the treatment? First of all, we have to educate the patient about sleep hygiene. We have to tell the patient what sleep hygiene is and how he has to implement it. And we have to tell him that all of these things, they are part of sleep hygiene. Okay, avoid alcohol, caffeine, nicotine, comfortable sleep environment, regular sleep schedule, no napping. So these are all part of it. A patient is coming with insomnia for sleep. You can choose anyone: sleep hygiene, relaxation therapy, cognitive behavior therapy. These are all the same, one or the same thing. Okay, and educate the patient that don't use your mobile or your cell phones, or don't use your bed for all these things. Don't put a TV in your bedroom, and don't read a book in your bed. You have to educate the patient that bed is only for sleeping. When you are sleepy, just go to your room and lie down in your bed and sleep. Don't use your bed for any of these extra activities. Educate him. Then also tell him to avoid heavy exercise within 3 hours of bedtime. Exercise regularly, avoid heavy exercise within 3 hours of bed. After that comes the pharmacological therapy. And always remember, we do not just start them on benzodiazepines. It is the last option. If the patient is coming, first sleep hygiene, cognitive behavior therapy, then we move on to melatonin. After melatonin, we can give them, still not getting better, we can start them on zopiclone or zolpidem. After this zopiclone, zolpidem, still symptoms are not getting better, then we can start them on benzodiazepines just for short time. Limited dose we will give them, and we will monitor them. That is just for 7 to 14 days. Okay. So we just don't immediately, our first option or first answer cannot be benzodiazepines. That is wrong. Then if the patient has some snoring problem, what do we do on physical examination? We have to check for obesity, any nasal polyps, any septal deviation, hypertrophy of the nasal turbinates, and large uvula and tonsils. And what will we give them? We will ask the patient to lose weight. He's obese. Because of that, if he's having snoring, ask the patient to lose weight. Ask the patient to sleep on the side. Still not getting better, use some nasal dilators, tongue retaining devices, mandibular advancement devices. This polysomnography or sleep studies, there are special clinics over here which deal with all these programs. So we don't just immediately send the patient, okay, the patient is snoring, and now what is the next investigation? Just send the patient for polysomnography. No, we have to start them on these conservative managements. Still, if the patient is not improving, then we send them for polysomnography. Okay. Similarly, for obstructive sleep apnea, it is very important. Patient might come in, or the patient is not concerned, but the wife is bringing in the patient. She says that my husband, at the night when he sleeps, he stops breathing. And it happens after every few minutes, or it happens very frequently. And I look at him and he's not breathing, and all of a sudden he starts breathing, and I get scared. There's something wrong with him. They can present it to you like this. Or a person working in some office, he's obese and he's coming to you and he says that, doctor, I feel sleepy all the time in my office. And on further history, you check that he's hypertensive, he is not even sleeping properly. He says that, yes, I do wake up multiple times at night, and I'm not able to sleep properly. So what is it? It is obstructive sleep apnea. What is the diagnosis based on? Nocturnal polysomnography. More than 15 apneic or hypopneic episodes per hour of sleep. But of course, not if they're asking you what is the diagnostic test, then yes, we have to write nocturnal polysomnography. Okay. Then what is the treatment for this? The treatment is weight loss and CPAP, continuous positive pressure airway. One treatment they're asking, what is the primary treatment in a patient with obstructive sleep apnea? Then this is the primary treatment, CPAP, continuous positive airway pressure. We have to write that. All of these are what? Conservative, like avoid sleeping supine, try to reduce weight, avoid alcohol, sedatives, opioids. These are the conservative measurement. Of course, we will educate the patient about all this. But along with that, the diagnostic main treatment is this CPAP, okay, continuous airway. Also, if the patient has OSA and it is not controlled by CPAP, what is the next step? Always report the Ministry of Transportation. Okay, because he cannot drive properly. He might be driving and he can fall asleep. There can be some serious injury. So we have to report to the Ministry of Transportation, and until and unless his condition gets better, they will cancel his license. He won't be allowed to drive. Okay, it's a reportable to Ministry of Transportation. Remember, they will just give you like obstructive sleep apnea. Patient is having obstructive sleep apnea. Who do you have to report, or what is the next step after CPAP, or he's trying everything, nothing is getting better, then report to Ministry of Transportation. Okay, and in these patients, there's increased risk of hypertension, 2 times increased risk, coronary artery disease, 3 times increased risk, stroke, 4 times increased risk, and arrhythmias. So they have increased risk of all these things. Most common is hypertension in them. Have to rule that out. Then is sore throat. Okay, sore throat, what is it? It is an infectious inflammation of the oropharynx. Very simple, we know that. Pharyngitis, inflammation of the pharynx, of the oropharynx. What are the red flags? If any of this is present, immediately refer. And mostly it is viral, that is adenovirus, rhinovirus, influenza, respiratory syncytial virus. It can be Epstein-Barr virus. All of these viruses, they can present with the symptoms of pharyngitis. If it is bacterial, most common is group B, beta hemolytic streptococci. Okay. And remember group A, beta hemolytic streptococci, it mostly occurs in children, like less than 17 years old. What are the symptoms of viral clinical presentation? Will be pharyngitis, conjunctivitis, rhinorrhea, hoarseness, cough. One differentiating feature between the viral and the bacterial is, in viral, there will be cough. In bacterial, there will be no cough. Okay. If the patient is presenting with cough, hoarseness of voice, any conjunctivitis, low-grade fever, non-specific, not very high, so it is most probably viral. And what are the common viral infection? Epstein-Barr virus, Coxsackie virus, hand-foot-mouth disease, and herpes simplex. Now, in Epstein-Barr virus, it is called infectious mononucleosis or also kissing disease. And it will, mostly the teenagers will present with it. Okay, and they will, what will they have? Pharyngitis, tonsillar exudate, fever, lymphadenopathy, fatigue, and rash. Or they can give you a scenario in which the patient is presenting to you with pain in the abdomen. Okay, and they were playing soccer or something, and now, all of a sudden they fell, and now they have very bad pain in the abdomen. They're becoming hypotensive, signs of shock. And on history, what history do they give us? They give us the history of recent upper respiratory tract infection. They say, yes, 1 week ago, 2 weeks ago, we had this, but now it is fine. And all of a sudden, this is what. So what could be the cause? It could be rupture of the spleen, splenomegaly, because this Epstein-Barr virus is a cause of, during this episode, patients have splenomegaly, and we always have to counsel them to avoid contact sport for at least 1 month. They are not allowed because the mass of the spleen, it enlarges a lot. So when there's a very big spleen, there are chances of rupture. So we have to educate them to avoid contact sport for 1 month. Similarly, and what is the test for it? The diagnostic test is a heterophil test or monospot test. Then, and the treatment is just symptomatic. If they are coming, we will just give them symptomatic treatment for Epstein-Barr virus if we are suspecting it. Okay. For Coxsackie virus, hand, foot, and mouth disease, it is mostly in children. Children who are going to school, children in daycares, they mostly present with this. Primarily late summer or early fall. Sudden onset of fever, pharyngitis, headache, abdominal pain, and vomiting, appearance of small vesicles that rupture and ulcerate on soft palate, tonsils, pharynx. Ulcers are pale gray and several millimeter in diameter, have surrounding erythema, and may appear on the hand and feet. So this is also symptomatic treatment. Just educate the parents, just tell them that, okay, during this time period, don't send the child to the daycare, to the school, keep them at home, and also give them symptomatic, like if they have fever, give them antipyretic for increased fluid intake. So just the symptomatic treatment we are going to do. Increase the hydration. For herpes simplex virus, what are the pharyngitis, tonsillar exudate, fever, lymphadenopathy, fatigue, and rash. Okay, so may have pharyngitis, which is of HSV. The cause is HSV. Similarly, they will present fever, lymphadenopathy, and symptomatic treatment will get better. Or if we want, we give acyclovir, but not for this pharyngitis. Then for bacterial, what is in bacterial? The patient will present with pharyngitis, fever, malaise, headache, abdominal pain, absence of cough. Signs are fever more than 38. Okay. Then tonsillar or pharyngeal erythema or exudate, swollen tender anterior cervical nodes, and halitosis. You should know this M Centaur. Okay, this criteria. If you know this criteria, you can easily differentiate whether it is bacterial or viral, whether we have to do further investigations, and whether we have to start the patient on antibiotics or no. So what is this criteria? You can remember it as M Centaur. M for mostly in that was males. Okay. And then C is cough, absent. Then history of fever, more than 38 degrees, 1 point. Tonsillar exudate, 1 point. Swollen tender anterior nodes, 1 point. Age, 5 to 14, 1 point. But if 15 to 44, 0 point. And above 45, -1. Patient has these symptoms, but the age is above 45. Then we are going to exclude 1. So depending upon this criteria, if the score is falling between 0 to 2, then no further testing and antibiotics are needed. But if the score is 3 or more, then what do? We do rapid antigen test, direct direct test, sorry. And if the RADT test is negative, then we have to perform the throat culture. Okay, for negative RADT, perform throat culture in patients under 20 and treat with antibiotics if cultures are positive. And what is the investigations for beta hemolytic streptococci? Gold standard diagnosis is throat culture, but the first test is RADT, depending upon the score. Increased risk of complication, and it is at increased risk in which population? Indigenous people. In Canada, increased risk in indigenous people. Remember, many things are, and this indigenous population is very important. We should know what diseases, what comorbidities, what are common in these people, because this is very important. There are still some communities of indigenous people in Canada where they live in reserves and proper medical supplies are not there. So some diseases are very common over there. So we should be knowing what is common in which population. Then we did this. Okay. Then for group A, beta hemolytic streptococci, what is the treatment? Treatment is penicillin. But remember, it has a complication of what is this? Rheumatic fever or glomerulonephritis. Post-streptococcal glomerulonephritis can be there. Scarlet fever can be there. But even it has a risk. But the treatment, if started within 10 days, then they can be prevented. So we have to wait for the culture results. If the culture results are positive, we start with the antibiotics. If not, then we will move on. Infectious mononucleosis, I covered this. I told you, avoid heavy physical activity and contact sport for 1 month or until splenomegaly resolves. If airway obstruction, give corticosteroids and ENT. Yes. And what are the red flags? These are the red flags here. Red flag in patient with sore throat. Persistence of symptoms longer than 1 week without improvement. Respiratory difficulty, particularly stridor, croup, etc. Difficulty in handling secretions. Peritonsillar abscess. What is difficulty in handling secretions? Like they might present with some drooling, and this drooling is common in peritonsillar abscess, Ludwig angina, there's epiglottitis. So it means if there's drooling, patient cannot breathe. Okay, so there's problem with the breathing and it is a medical emergency. Immediately have to intubate the patient. Then difficulty in swallowing, Ludwig angina, severe pain in the absence of erythema, supraglottitis or epiglottitis, palpable mass, neoplasm, blood in the pharynx or ear, trauma. So if the patient is presenting with a high-grade fever and runny nose, along with that he has some drooling, then it means that the patient is not able to breathe and he might go in respiratory distress. So in such cases, what are we going to do? We're going to immediately refer to the emergency department. If the patient is in the emergency department, we immediately have to intubate them. Okay, and this is the end of our family medicine. This palliative care, it will all come in the ethics, then we're going to do it separately. Okay, this is the end. Yes. So, okay. End of family medicine. Next week, we'll start another topic. Let me just